welcome to session 62 of the International IVF Initiative that is titled as The Metrics. And I am honored to be co-hosting this session with Dr. Dean Morbeck. And Dr. Morbeck is the scientific director at the Fertility Associates of New Zealand and Sunfert International Fertility Center. And he is the honorary associate professor in the Department of Obstetrics and Gynecology at Monash University, as well as honorary lecturer at the University of Auckland. He oversees science in IVF clinics throughout of New Zealand, Malaysia, that annually perform over 4,500 fresh cycles. Prior moving to New Zealand, Dean was the associate professor at the Mayo Clinic, and prior to that, he was in private practice in the US over 10 years. He obtained his PhD from North Carolina State University and his MBA from Augsburg College. His research has focused on quality in the laboratory, from culture media protein and oil to how embryologists grade and decide to use blastocysts. Obviously, his bio is much longer, and if you want to see the whole bio, then please go on the website, ivfmeeting.com. Over to you, Dean.
Great. Thank you, Peter. It's great to be here again. It's been a little while, and thank you for that introduction. And I will again refer everyone to the bio for Peter. However, I'm going to give a little brief bio now. Dr. Nagy obtained his MD and his OBGYN specialty degrees back in the late 80s and 90s at Semmelweis Medical University in Budapest. And he obtained his PhD at Free University of Brussels on gamete micromanipulation and ICSI in 1997, so in the early days of ICSI. He's, with his team, developed a highly efficient protocol for oocyte vitrification that has led to the development of my egg bank. He's a member and board member of several national and international professional societies, and he's just authored a whole bunch of books, publications, and just, again, I refer you back to the website to see the whole list of what he's done. And so back to you, Peter.
Thank you so much. I really appreciate it. And then just for the audience, as a reminder, before we start the presentations, that if you have questions, and we hope that you are posting many questions, please go to the Q&A session, put your questions there and not in the chat, okay? And we very much appreciate that. So let me introduce
Let me start, Peter.
Yes.
If I can start, actually, forgot to mention that the title of this session is The Metrics. It's all about best practices in egg collection and embryo transfer. What are the variations of these techniques over the world, and what do high-performing clinics do? And then there's going to be a separate session at the end about a scheme started by ASRM to simulate and train clinicians to perform embryo transfer better. So there's obviously a lot that the embryologists can learn from clinicians and vice versa. And so now let's get into it, Peter. Go ahead and—
Absolutely. I mean, this is a fantastic session because it's combining both the clinical side and the laboratory embryology side. The first two presenters are Dr. Brad Van Voorhis and Dr. Amy Sparks, and Dr. Van Voorhis, MD, who is also professor and interim chair in the Department of Obstetrics and Gynecology at the University of Iowa Carver College of Medicine. He, along with an excellent team of physicians and embryologists, pioneered the use of single embryo transfer in the United States, which is now the standard of care based in part on research done at Iowa. Dr. Van Voorhis has been the president of the Society for Reproductive Endocrinologists and the president for the Society for Assisted Reproductive Technology, SART. For the full bio, again, I refer everyone, please visit the ivfmeeting.com website. And he will present together with his colleague, Dr. Amy Sparks, who is a PhD and clinical assistant professor in the Department of Obstetrics and Gynecology of the Roy J. and Lucille A. Carver College of Medicine at the University of Iowa. Dr. Parks has served as director of the andrology and in vitro fertilization laboratories at the University of Iowa since 1993. and she has served as president of the Society for Assisted Reproductive Technology, SART, co-president of the Society of Reproductive Biologists and Technologists, and also chair of the SART Registry Committee, and currently serves on the American Society for Reproductive Medicine's Board of Directors at large. For the full bio, again, please visit the ivfmeeting.com website. And this presentation is the art over ovum pickup, X over easy. So please, Brad, this is for you.
Okay, thank you very much, Peter. Can you hear me and see my slides?
Yes.
Okay. So Dr. Sparks and I have nothing to disclose about this talk today. The objectives are to describe preparation of the patient before the egg retrieval, talk about performance of the egg retrieval, tips for success, and then also mention optimizing communication between the physician and the laboratory staff. For preparation of the patient, it all begins with the ovarian stimulation. As you know, at the University of Iowa, we like to see at least 2 follicles at 18 millimeters or greater, and 1 additional follicle at 15 millimeters or greater in mean diameter to help ensure that egg maturity is reached. We're also interested in whether or not a hydrosalpinx or endometrioma is present, because these are the only patients that we give antibiotics to during the egg retrieval due to the higher risk of infection in those individuals. We also assess whether or not the ovaries are accessible by the transvaginal route as we prepare for the egg retrieval. We always communicate with the laboratory about the timing, of course, of the trigger and about the anticipated follicle number. We also like to ensure that the trigger dose was actually given. We've had instances where patients failed to take HCG. So if HCG is being used, we have patients check a home urine pregnancy test the morning following the trigger and report the results to us. If we're using a Lupron trigger, we check LH and progesterone the next day. So the critical communication that occurs is, was the trigger shot given? Next, we have a pre-procedural huddle with both the patient, the physician, and the lab staff to review the consents and understand what we're doing for that patient. During the retrieval, I like to hear early on whether or not the lab is getting eggs from my retrieval process. And then at the end of the case, the lab is informing me of the final egg number, which I relay to the patient. All subsequent outcomes in our center, fertilization rate, development, et cetera, are communicated to the patient by the lab, often via done electronically, unless there's a problem, in which case physicians are calling the patient directly. We don't use antibiotics for retrieval at our center. This was a change we made about 5 years ago. I've been very happy with that decision. It avoids the yeast infections and complications of antibiotics that can occur unless we have an endometrioma that we punctured or a hydrosalpinx. Those patients get antibiotics. We use saline to prep the vagina, and we use propofol, a fast-acting, fast onset, fast recovery anesthetic with a nurse anesthetist at the head of the bed. This is our setup at the University of Iowa. I particularly like having the boom with the ultrasound monitor directly in front of me. It's very ergonomic and avoids pain in my neck. As I get older, this is more important. This shows the other view where we have a pass-through window for easy access, passing the aspirates back to the laboratory. In setting up for ovum pickup, we always check the system first, of course, ensuring that the suction is working. We use a pressure of 100 millimeters of mercury for suction, although you'll read in the literature anywhere from 100 to 200 millimeters of mercury being used. Of course, a high frequency transducer is used. We use a single lumen needle, 16 gauge needle for our retrievals, and we use 36 hours for timing of the trigger to the actual retrieval, although it does vary from center to center. The basic principles are that we start by observing the pelvis with the ultrasound. I like to choose the easier side first, simply because after retrieving that first side, sometimes the other ovary becomes more accessible as the first side is decompressed. We always check for vessels using Doppler as needed to try and avoid puncturing a larger vessel around the ovary. I tend to insert the needle in the middle of the ovary and then keep the needle tip in the center of the follicle as it's collapsing around the needle tip. We move from follicle to follicle, adjacent follicles, trying to avoid repetitive punctures of the vagina or the ovarian cortex. We generally try to retrieve all follicles, but don't go to excessive time trying to get very small follicles, less than 10 millimeters, as most of those eggs, if there are eggs present, are immature. This just demonstrates the initial sweep of the pelvis by ultrasound, looking at the endometrial stripe and finding the ovary, and you can see the ovary here easily accessible. And then as we sweep to the other side, that ovary is less accessible, further away from the needle. So I would start on the side that I initially showed you for this particular egg retrieval. This shows the actual egg retrieval process. In a moment, you'll see the needle puncturing the follicle. Here it comes in through the track. I try and keep the tip of the needle in the middle of the follicle as it collapses. And then we curette the follicle by gently twisting the needle in an attempt to increase egg number from the retrieval. And here we are going into the next follicle. Again, keeping the needle tip in the middle of the follicle as it collapses. So we do no longer flush follicles in our center. This was a change we made a number of years ago because Cochrane review data suggests that it does not improve the live birth rate. It doesn't increase egg yield, and it certainly takes longer to do those retrievals. So flushing is not something that we do in our center. I think it's unnecessary. We do curette the follicle to try to increase egg yield, although the data behind this is rather limited. It's simply done by gently rotating the needle inside the follicle after the fluid has been aspirated. This demonstrates the only study in the literature that I could find about curetting. It was a retrospective study showing that with curetting, more eggs were retrieved, more mature oocytes. It did take a little bit more time to do the retrieval, but it did generate more embryos to be cryopreserved, although the initial live birth rate in this study was not affected one way or the other by curetting. Still, it's something that we do. We all know about tough retrievals and the management of that, including pressure on the abdomen, reverse Trendelenburg, and in some cases, transmyometrial or even transabdominal retrievals are necessary. And generally, these are associated with perhaps slightly fewer eggs being retrieved, but pregnancy rates being similar. So complication rates are low from egg retrieval. I've listed them here, but in general, it's a very safe and easily performed procedure with a very low complication rate in experienced hands. At this point, I'm going to move on to Dr. Sparks, who will talk about the lab's role in oocyte retrieval.
Thanks, Brad. So what does the lab do? How are we involved in the egg retrieval? Well, we're there to find and protect the oocytes. We need to find the eggs quickly, and we want to optimize the oocytes environment by maintaining sterility. We want to maintain the temperature because we know the meiotic spindles are sensitive to temperature changes, and we risk depolymerization of the spindles in the oocytes. And the oocytes are unable to regulate their own pH, so we have to regulate it for them. So we have to make sure the environment that we have the eggs in has pH right around 7.3 to 7.35. All right, next slide. Brad, can you advance it? He's trying.
It's not advancing for some reason. There we go.
There we go. So the day before the egg retrieval, we do prepare our retrieval tubes, and we warm them at 37 degrees overnight. We use a zwitteronic buffer, HEPEs, for our retrievals. I have noticed at some centers that they go ahead and have the OR staff pour the retrieval, the oocyte tube media into the tubes in the procedure room. Honestly, it's not a very sterile environment. It's not sterile environment, frankly. If you do microbial sampling or particulate counts in your procedure room and you've had your OR staff managing the preparation of these tubes, you might think twice when you get your results. So we prepare all of our tubes in the lab, warm them overnight. Tomorrow we've got 6 retrievals. For some of you, that's not many, but for us, it's a lot. It's nice to have all the tubes ready to go in the morning. Pre-equilibrate, obviously, the insemination dishes. And then if you're using a bicarbonate buffered media for egg washing and holding, that media needs to be pre-equilibrated as well. Okay. So on the day of the retrieval, you've got to go through your checklist for QC. You're going to do temperature checks of the room, of the lab. Check every heated surface, dry bath temperatures, incubators, and the refrigerator that's holding that precious media that you'll use for subsequent days of retrieval. We do measure the pH of our insemination media every day. That may be overkill for some of you, but we think it's very important. And then, like Dr. Van Voorhis said, we have the timeout where we're reviewing the consent, making sure that we're completely ready for the case and prepared to do everything that both the patient and the physicians are directing us to do. All right, next slide. So the setup, as you saw in the photo that to the left, this is the dry bath that we use in our OR. The dry bath has its own digital display, but of course I don't trust that all the time. So we have 2 thermometers, a spirit-filled thermometer as well as a digital thermometer. Now that digital thermometer makes it easier for everyone to view temperature if they're not right in front of the dry bath. And it does track high and low temperature. So if you have a temperature extreme, you do have a track. So if something goes wrong with the case, you can at least go back and check that thermometer and make sure the temperature held. On the right, we have the window to the OR. Nurses are going to put the retrieval tubes in the dry bath that's on the Mayo stand. That dry bath also has a spirit-filled thermometer that we're checking every day. And then finally in the hood, we have another dry bath. For us, we hold our oocyte collection and oocyte wash solutions in this dry bath. I made this picture kind of pretty for you. I took a few things away. So Brad, if you can just click once, we're going to show one more picture in this slide. So this is the reality. We have a heated hood. The stage that is surrounded by the black line is all heated. And because we have the dry bath sitting on it, we've identified that portion of the stage to be too hot. So we have a piece of red tape that says, do not put dishes here. I'm also pretty concerned about people possibly bumping the knob on the dry bath. So we have Nalgene caps taped over every knob of every dry bath so no one can accidentally adjust the temperature of the dry bath, only intentionally. You have to remove the tape and lift it. Okay, next slide. So as Dr. Van Voorhis mentioned, stop flushing the follicles. And to give you an example of the change it had in our program, I looked at Dr. Van Voorhis' statistics for the first decade when he was using the double lumen and flushing. And the average time for the first tube to the last tube coming to the lab was 19 minutes. When we went to the single lumen with no flushing, we reduced it down to 10 minutes. I mean, that is a tremendous change, and trust me, oocyte numbers, follicle numbers did not change over time. So stop flushing, be brave. Next slide. So other time savers, not only can you eliminate the flushing, but it's important to have your oocyte wash and your oocyte holding medium in the hood. I've been at centers that go to the efforts of, they find the oocytes, and they're going to the incubator and walking back and forth. So either have your solutions in the hood, or if you're working in an isolate, have them at the ready. Some choose to use bicarbonate buffered dishes, and they'll have a funnel inverted over that feeding a trigas, that's great. We actually use a bicarbonate buffered media, and we just fill these 5 mil snap caps, the small ones, up to 4.5 mils. We'll go in and out of those tubes very quickly. The pH and the temperature stay stable at the bottom of the tubes, and we'll put up to 10 eggs in those small snap caps. The large snap cap is holding our egg washing medium. Okay, next slide. So the other time saver that may be a little bit unique to us is most programs just go ahead and dump the whole tube of aspirate into a 100 millimeter dish. We do things a little differently. We use a fire polished 5-inch Pasteur pipette that's connected to a 5 cc lower lock syringe, and then we have a silicone bung that connects the two of them. And we'll go down into the tube and draw up just the cells that are on the bottom of the tube. And as you can see on the right, we can watch the cumulus complexes come out of the pipette as we're on the scope. We think it helps us identify the oocytes a little faster. It, we find 95% of the eggs this way. We still do look at the remaining fluid in the tube, but I think this is something that can speed things up for you. All right, next slide. So quality assurance performance indicators, this is an important topic for all of us. We have to measure our quality, and certainly we look at fertilization rate, and we watch our embryo development, but we also want to see what our oocyte recovery rate is. So we measure the oocyte recovery rate by physician by looking at the total number of oocytes retrieved divided by the number of follicles that were 10 millimeter or greater at trigger. We're aiming for a competency minimum for physicians doing a minimum of 40 retrievals in a year, average recovery rate of at least 85%. I can say that all of our physicians recover at least 90% eggs from 90% of the follicles that are greater than 10 millimeters at trigger. I think this is also a surrogate measure of how our sonography is working and how accurate our sonographers are with their follicle measurements, and also embryologist performance in identifying oocytes during the retrieval. So that is how we go about oocyte retrieval at the University of Iowa. Thank you so much.
Great, thank you, Amy and Brad. That was fantastic. I'd like to point out that this session, these first two sets of talks on retrievals and transfers are sponsored by Cook Medical, and we'd like to thank them for that sponsorship. And we'd like to just take a time now to jump into a question. And this is going to be a question mostly for you, Brad, but Amy, chime in. You guys have done a lot of work and have over the time had really good outcomes and have been champions for single embryo transfer in the US. And you've also been working on the topic of, what do best practices do in the US? There's many points of our contact between the lab and the theater or the operating room that we, often are experiencing around the world. And the three things are, is the pressure set right? Can it be too high? Do you really need to use single lumen, or is double lumen still necessary? Because I still see that at places. And then also the third one, which I forgot about. So those two, those are the main ones. If you could just say, obviously you shared your practice, you don't do that, but what about in general from what you see from best practices? Are those two involved?
Yeah, I think they probably are, although I haven't taken a comprehensive survey of pressures. I did a study 10 years ago, and for the most part, at least in the US, the aspiration pressure was closer to the 100 than the 200 mark that you were just alluding to, millimeters of mercury. So we've tended to go with lower pressure retrievals. I don't honestly know if it changes the outcome. In our own center, we've always just had it at 100 millimeters of mercury as we set our aspiration pressure. And then in terms of single lumen versus double lumen, we used to use double lumen needles. As Amy alluded to, times were long. We then switched to a time period where with few follicles, we'd use double lumen and flushing, and with larger follicle numbers, we'd use single lumen. until finally we just said, look, we're not getting any difference in egg number, and we're 100% single lumen aspiration with no flushing. I don't think it's necessary. Even for those with small follicle numbers, and it saves time and get equal outcomes. So that's the way we've moved 100%. There's differences of opinion, but
Yeah.
Yeah, and I'd like to comment. Yeah, go ahead.
Go ahead, Amy. Yep.
Oh, the weaning process was very intentional, though. It was 8 follicles, 10 millimeter or greater. Less than that, then we'd go to the double. So it was a stepwise process to get people to be confident with it. I think that's important.
Which I've gone through a few times now in different centers, and everyone's ended up on single lumen. So that's good news. Well, thank you guys both. And we'll be looking forward to having more discussions in the Q&A session. But next up, we've got the transfer session. And I'd like to again introduce our speakers. I've already introduced Dr. Peter Nagy. And the only thing I'd like to add to that introduction is that, he did study at Semmelweis Medical University. And maybe in another time, we can hear more about how much they learned about Semmelweis that we've since learned about from, Atul Gawande and his books. But I'll move on then to Dr. Shapiro, who's a native of Miami, Florida, and a graduate of Emory University School of Medicine in Atlanta. He received his OBGYN residency training at the Pennsylvania Hospital in Philadelphia and his REI training at the University of Connecticut in Farmington. He joined the staff of Reproductive Biology Associates, RBA, in Atlanta in 1995 and has served as RBA's medical director since 2005. Shortly thereafter, with Dr. Nagy and Jeremy Chang, after they showed extraordinary results with egg vitrification, they started the My Egg Bank. So off to you guys.
Thank you. Thank you, Dean. That was very nice. All right, let me see if I can figure out how to do this. Yep, there we go. Now we hit slideshow. And then we're good. All right. So welcome. We're going to talk about embryo transfer and the consensus opinions on embryo transfer. And Dr. Nagy will be presenting some slides toward the end. The goal, of course, is to get everybody pregnant. This is a meme from a 1989 movie called Weird Science. That's Kelly LeBrock, in case anybody's interested. She was married to Steven Seagal for a while. This was a comedy movie. She's not going to shoot anybody. Okay. 2017, the American Society for Reproductive Medicine formed, actually slightly before that, formed a committee to look at standards of practice. And one of the subcommittees was the Embryo Transfer Advisory Panel. The panel was tasked with doing several tasks. First of which was to survey the IVF practices, primarily in the United States, and their lab directors on what typical practices they use for embryo transfer. We'll hear more about the simulator later. The committee also engaged private industry to develop that. And this was all part of a larger goal between 2014 and 2019 at ASRM. And this particular subcommittee was formed because there was recognition at that time that there was wide variation in pregnancy rates between physicians, even within practices. And also fellowship training was not quite up to snuff in the US related to experience with embryo transfer. And the folks who are going to present the simulator will talk more about that. So ASRM came up with a 12-step program. We're going to go through these very quickly. Most of these are just standards for any medical practice, including hand washing and the like. Within the 12 steps, though, are a handful of steps in which there are controversies within embryo transfer. Let's look at these here really quick. Prepare by knowing which way to go, analgesia, timeout, and then ultrasound to scan the endometrium and know the direction of the catheter, and then ultrasound is maintained, of course, during the transfer. Of course, wash hands, clean off the cervix, Remove mucus is one of the areas of contention, actually. Step 8 is load the catheter. And step 8, special consideration. This may be done with or without a trial transfer first. The catheter may be done, may be set up with or without the inner catheter to start. And it may be done with or without the embryo preloaded. None of that seemed to make a difference. The only thing that the committee was able to find that seemed to make a difference was the use of a soft catheter relative to a hard. Well, nobody uses a hard catheter anymore, so this is more of historic interest, but that is established. Step 9 is placement of the catheter. There was some debate about that. Then, of course, you press the plunger, check for retained embryos, and then the patient can leave. At RBA, we have a 13th step. I throw an elven magic spell. That's the Tengwar strip from Lord of the Rings. If anyone can translate that, I'll be very impressed. So what does the science say about each of these 12 steps? Well, first, you got to grade the science itself. And there's consensus in our field as to what would constitute level 1, level 2, and level 3 type data. Level 1 are the well-randomized RCTs. Level 2 are mostly case controls and cohort studies, and some are comparative time series. The key thing about level 2 is they are basically without randomization. They're not bad studies, but they're retrospective primarily. And then level 3, that's a thought leader opinion, case reports, committee summations, but not any statistical analyses on which you can hang a hat. So again, the panel was organized to do a systematic review of the literature in addition to considering the existing practices of REIs and their lab directors. So what does the science say about the first 4 steps? Well, step 1 is just know which way to go with the catheter. Step 2 has to do with analgesia prior to transfer. There is fair evidence that acupuncture actually has no impact on pregnancy rate. Grade A, by the way, would be good evidence. Grade C is insufficient evidence. There is insufficient evidence to recommend for or against any other measure for comfort, prior to the transfer other than for comfort. That's the only thing you're going to accomplish. It's not going to improve pregnancy rate. TAS is a form of acupoint electrical stimulation. There's actually one RCT that supports the use of this technique to improve pregnancy rate, but it's standalone. And there is basically insufficient evidence to recommend either for or against Eastern medicine interventions in general. Transabdominal ultrasound is very well studied on this point. This would be step 4. There are 9 RCTs that support the use of transabdominal ultrasound, and there is good evidence that routine ultrasound should be used for catheter placement during the transfer. Steps 5 through 8, obviously you have to wash your hands. Flushing and wiping the cervix, there's no actionable data, but removal of cervical mucus, there is fair evidence based on a handful of studies that this maneuver will improve pregnancy rate. And so I think it's become a standard for all of us to remove cervical mucus, though there's no one preferred method. And then with regard to step 8, there is no consensus on the technique for prepping the catheter, but there is, like I said, good evidence for using a soft catheter. Now steps 9 through 12 deal with what happens actually at transfer. So where to place the catheter tip, that's step 9. Consensus exists through fair evidence that it should be in the mid to upper third, but no closer than 1 centimeter to the fundus, that kind of placement optimizes the live birth rate. There is also fair evidence that the catheter should be removed immediately, that there should be no delay in withdrawing the catheter away from the site of deposition. At RBA, we do kind of a hybrid where we pull it back immediately, but then Dr. Nagy, the embryologist who's pressing the plunger, will press the plunger again after we've backed up a bit. And then I do a little spinny thing as I'm backing out, but that's how I was trained. I'm not sure that makes a difference either. The subject then goes to what happens if an embryo is stuck in the catheter. And there is fair evidence that immediate retransfer of a retained embryo does not affect the implantation, clinical pregnancy rate, or the pregnancy loss rate. And in those data sets, it does not matter apparently whether you change to a new catheter or not, though in the survey, most people did change to a new catheter. And then interestingly, there is very good evidence that there's no need for bed rest after transfer. In fact, I tell patients they can pogo stick home, which has become something of a standing joke at RBA. So this is a sample of commonly used catheters, each with an inner and outer. At this point, I think Dr. Nagy is going to take over and talk about the loading of the catheter and optimal technique for that.
Yes, thank you very much. Would you mind to unshare?
Yep.
And then I can try to share my presentation. I think it's this one. And here we are. So I just wanted to show the the 3 different options that how you can load the catheter with the embryos. Obviously, you shouldn't put 3 embryos, not even 2 embryos. We should put only 1 embryo in the catheter. I just put more embryos that you can more easily see the position of the embryos. So the first one is the full column option. I would be a little bit worried to use that because if you touch the opening part of the catheter somewhere, maybe there is the capillary effect that could draw out the medium, perhaps together with the embryos. That wouldn't be good. So the other option is, which is the same as above, but you put a little bit of air at the top of the catheter. And the third one is that you create a air pocket before and after where the embryos are in the medium. I think the few studies that compared these last 2 options, they didn't find really any significant difference in the outcomes. I also wanted to just put this slide out for you to think a little bit about the importance of the diameter of a catheter. There are many different diameters, as you saw on the previous slide from Dr. Shapiro, and the thinner the catheter, it actually gives you a longer column if you aspirate the same volume inside of the catheter. So you get probably a better control than you are using a thinner catheter. And I also wanted to show, the syringe options. There are obviously many different syringes available. I know that, several years ago, actually about 15 years ago, we still used the 1 ml syringe. Then I accidentally discovered another type of syringe that was not really assigned to use it in the IVF. Like back at that time, it was over 15 years ago. But I always wanted to find a better syringe than the typical 1 ml syringe. And I discovered this 0.25 ml syringe that gives a very good control. And you can see that because the size is the same as the 1 ml syringe, you will have a much longer column distance here when you are aspirating the medium together with the embryos. So that syringe will give a better control. Also, I like about this syringe that how it is joining with the embryo transfer catheter, that is not just simply push it in, but it's also a screw drive, which is much safer to keep together the syringe and the catheter. We also did a study in 2005 that was comparing how was the importance of the different parameters that we were observing at the time of the transfer, how it is correlating with pregnancy or non-pregnancy outcome. This was performed in good prognostic patients. And what we observed that the use of stylet, if we had to change catheter, that had to use an extra catheter, resistance, what you feel during embryo delivery when you push the syringe lever, or lack of forward flash on ultrasonograph, and also the total time that you needed to complete the embryo transfer were correlating with the pregnancy outcomes. Other variables that we were registering, they were actually not correlating with pregnancy outcomes. And then I give back here the microphone to Dr. Shapiro, and this is the embryo transfer.
Yep. So it's actually an old video, but it's still what it looks like on our current ultrasound machines. So here's the uterus is in mid-plane. You can see the bladder above. The endometrial stripe is in the center of the screen. And here you can see the introduction catheter, the outer, coming up to the level of the internal os, right there. Dr. Nagy is moving his pointer to that site. In a moment, the soft catheter will be passed through into the mid-third of the endometrium. There you can see it advancing very slowly into the mid-third. And then you're going to see the fluid flash in about 1 second. The tip is in the mid-third here. It's his red dot's directly under it. It faded out as it went to the middle. But there's the dot right there. There you go. And so then the catheter is being removed immediately. And the dot, the air fluid interface, confirms the placement, which is mid-fundal. And you can see from the hash marks on the side, the scale, each hash is a 1 centimeter. It was about 1 centimeter from the fundus. And that's that.
And
Thank
that
you.
was it. Thank you.
All right. Well, thank you guys for that session. And let's just again thank Cook for sponsoring these sessions. And we've got a whole bunch of questions. And I'm just going to start with one quick one from two people asked the same question or a similar question. Elke Clerks, as well as Manishka Dev Chowdhury from Maharashtra, India. And that regards the ideal volume of media in which the embryo must be loaded, 10 to 20 or 50. Does it affect pregnancy rate?
Right. So, you know, I prefer to load the minimum possible volume, which is probably half of, it's around 50 microliter or 60 microliter in total. But if it's possible to get it even lower, then it's probably better. Obviously, we have to be also careful that there is enough transfer medium behind the embryo. So when you push out the embryos from the catheter, you have to make sure that, you know, the embryos are actually leaving, you know, the catheter and will be far enough inside of the uterine cavity from the catheter that when you pull back the catheter is not going to pull the embryos together with them, if that makes sense.
Yeah. Good. Okay, great. Well, there's been other questions along the same line that we'll get back to at the Q&A. Again, I'll just thank Cook for those first two sessions and then hand this over to Peter to introduce the next session.
Thank you very much. And the next session will be presented by Dr. Richard Reindollar and Kate Ray. And Richard and Reindollar, MD, completed his tenure as the CEO and Executive Director of the American Society for Reproductive Medicine, December 31 at 2020. He is Professor Emeritus of Obstetrics and Gynecology at the Geisel School of Medicine at Dartmouth, where he was professor and chair from 2005 to 2014. He's a past president of the Society for Reproductive Endocrinology and Infertility, the North American Society for Pediatric and Adolescent Gynecology, as well the New England Fertility Society and the American Society for Reproductive Medicine from the conclusion of the 2013 ASRM annual meeting until he became the Society's executive director. Dr. Reindollar was the principal investigator of two large NIH-funded infertility clinical trials, the FAST and the FORT-T trials. And obviously, this is just a very small part of the full CV for Dr. Reindollar. And please go to the ivfmeeting.com website to see the full bio. And he will be presenting together with Kate Ray, Kate has been with the American Society for Reproductive Medicine for 13 years, and he is currently the Director of Special Projects and Corporate Relations. Much of his work at ASRM has involved various initiatives in stimulation for reproductive surgery and embryo transfer, serving as the ASRM representative at the Council of Medical Specialty Societies Stimulation Workgroup. He has served as co-director of the ASRM embryo transfer program since project inception, that was in 2015. And again, for the full bio, please go to the ivfmeeting.com website, and they will be presenting an overview of the ASRM embryo transfer simulator program and the findings from this embryo transfer certificate course. And we are very much honored that both of you are able to join to this webinar and present your findings. Thank you.
Thank you. Thank you very much. Thank you to the I3 organizers and our host, Drs. Morbeck and Nagy. And thank you for those nice remarks, Dr. Nagy. We're excited to be a part of this today. Much of this presentation is actually going to dovetail nicely with Dr. Shapiro's comments on how all this came about in terms of when he was discussing the protocol for embryo transfer. So what I'd like to do first is to go through a few slides just to give you some perspective on what the embryo transfer simulator is, and then save the last portion for Dr. Reindollar to talk about our program, the recent article in Fertility and Sterility, and how we're using the simulator for training. So very quickly, I will, nothing to disclose. Are you able to see, am I looking at the right slide here?
Yes.
You did it, thank you. So here is a look at the embryo transfer simulator. You have the laptop and docking station. You have the ultrasound, you have the pelvic model, you have the interchangeable uteri. And so that is the front-facing view there. The 5 interchangeable models that we're using, we call them A through E, but that corresponds, yes.
You do not have only the introduction slide is showing.
Oh, I'm sorry. Thank you for letting me know that. Let's see. Is it moving now?
Yes.
Okay, thank you. So nothing to disclose. Okay, so here is thank you, Dr. Reindollar, a front view of the simulator. We have the laptop docking station. We have the pelvic model, the interchangeable uteri, A, B, C, D, and E. Those 5 models correspond to an axial uterus, an anaflexed uterus, a uterus with a tortuous or S shape. We have one that has a ridge and a false passage, and one that's retroverted is our newest one. We have a choice of 2 embryo transfer simulators that you can use. The first one that was developed back in 2015 was the Wallace Classic. We used that for a number of years, and we've just recently added the Guardia Access. And the reason for doing that is because these two catheters have differing characteristics. And so we believe that adds to the simulation training for the different cases. What I'd like to do is just briefly show you a few in-simulation views that you see on the simulator when you're doing the cases. Here is a full screen view, and you can see the ultrasound view. We have calipers that you can use. We have what we call an outside view or an animated view. This can be turned on or off, but this will show the catheter going through the cervix, through the uterus, into the uterus. Again, that can be turned off. You are able to select your different catheters off the navigation panel. We have a patient note on every case that comes up. In this particular one, this is the case that has the posterior ridge and the false passage. So that will help us to choose our embryo transfer technique. Here is an example of how the catheter shows up in the ultrasound view, as also in the outside view here. Okay. And here we can see the catheter tip. And then you can see over here, obviously, in the outside view as well. And after we expel the embryo in simulation, the position of the air bubble here on the ultrasound and on the outside view over here. At that point, we would remove the catheter. Here's just a brief video that I've included. This is on the case with the posterior ridge and the false passage. So I'll just play through this. You can see me coming in on the right over here and on the ultrasound. So I'm navigating. You can see I'm getting caught into that. I've cleared the posterior ridge, but I'm getting caught in the false passage here. And I'm doing this a couple of extra times just for the purpose of this demonstration here, so that you can see that catheter go into that false passage. Okay. So I'm using, in simulation, I'm using in the afterload mode. I'm actually using the Wallace catheter here. If we were using the Cook catheter, it would be a two-step. But the embryo is in the incubator safely. So I'm able to navigate through, until I feel it's time to do something different. Now, here I'm going to grab the stylet. Okay, now we realize that most people would not use a stylet or would minimize the use of a stylet. But in simulation, we want to teach all the tools that we have on the tray. And so with the stylet, I'm able to easily navigate past that false passage and enter the cavity. At this point, I'm calling for the loaded embryo transfer catheter, and that is being inserted through the outer sheath at this time. You'll see the tip just momentarily. There it is here. And then so I'm going to pull back on that outside catheter there, and I'm going to position myself to where I want to be, and I'm going to expel the embryo. And what is left behind here is going to be the air bubble and the air bubble over here as well. We will remove the catheter, and the next step in the simulation will take us to our metrics. And the metrics that we're scoring, which Dr. Reindollar is going to talk more about in terms of the how we came about on the course and the data that we collected that went into the fertility and sterility article. But we're working on a 155-point basis here. In this particular metric, I'm actually doing a different case. So it's not the one you just saw. But here I touched the fundus once on purpose to show you that that will register. My catheter tip was in the ideal zone. That's either your 1 to 1.5 off the fundus, 1.5 centimeters off the fundus. I was there. Where was I exactly on my catheter tip? 1.4. The duration of the embryo transfer is when I came in with a loaded embryo transfer catheter. So when I came in and then expelled the embryo was 16 seconds. You can see that I passed the loaded inner catheter tip past the internal os twice. That's once going in, once going out. So for someone that's training, we want them to be aware of how many times they're coming in and out with a loaded embryo transfer catheter. We measure the velocity of the expulsion, but there's no data that actually will back up whether faster or slower is better, but we believe that slow and steady is the goal. So with that, I'm going to turn it over to Dr. Reindollar to continue on.
Keith, we lost this.
Oh, my apologies. My apologies, folks. Here we go. Okay, Richard.
Thank you. And I'd like to also thank the organizers for inviting us to show the simulator and the curriculum that we've developed from it. Perhaps, Keith, I'll have you, can you advance the slides for me, please? So what I'd like to do over the next few moments is to talk first a little bit about why we got into this initiative and what we've learned as a result of it.
Hang on, Richard. I'm just, let me go back here. If I can capture that. Okay, so I'm having a little technical difficulty here. Here we go, Richard. Can you see that now?
Yes, I can. Thank you.
Thank you. Okay, thank you for your patience.
So in thinking about why we did this, the first thing is to understand what's the role of embryo transfer in pregnancy success. Can you go to the next slide, please? In 2012, the CDC presented these data that showed that in the 17 years from 1995 to 2012, remarkably, the pregnancy rate increased every year. Next slide. And what was remarkable was it did so while at the same time the number of embryos transferred decreased. And as we know, the pregnancy rate plateaued a little after 2012. Next slide. A lot of us ask, what are the reasons for the increase in pregnancy rates during that time that were so dramatic? And of course, we believe that the laboratory gets most of the credit, not only for its improvements in culture environment, but also the assessment of embryos. We also know that oversight by the registries, SART-CORS or CDC, helps to improve pregnancy rates as well. One of the areas that was largely overlooked was the role of the embryo transfer in the pregnancy success rates. And that was despite the fact that when moving from a stiff transfer catheter to a soft one and adding ultrasound, pregnancy rates significantly increased. Next slide. The next question is, what is the role of the clinician who's performing the transfer on the success rate? And as can be seen here, there is tremendous variation from the best success to the lowest success, although you can see here that most individuals varied around the middle of the bell-shaped curve with these outliers. And it's interesting, next slide, there are those who will say, my pregnancy rates from transfer aren't as good because I have more difficult patients. And Richard Scott's group presented this abstract at the ASRM 2016 meeting that actually addressed that or one aspect of that. They looked at 11 physician success on approximately 246 euploidic transfers each for a total 2,700 euploidic transfers, and showed that the pregnancy rates varied significantly between the worst and the best performing physicians. And that if the best performing physician performed the transfers for the physician with the lowest success rate, there was an additional pregnancy every 6 transfers. Next slide. There are other, next slide. The other data that really spurred us on to develop this program was from the survey that you heard Dr. Shapiro talk about at the last talks. And in that survey to medical directors of SART programs, one of the questions was, what role do fellows have in training on live transfers? And you can see here on the left that 50% of fellows either do 10 or less live transfers, and the other 50% do no transfers at all. So we realized that there was a tremendous gap in performing transfers and teaching fellows to do live transfers. Next slide. There are other studies as well that also point this out, and most recently in 2020, Feinberg's group demonstrated that nearly 50% of fellows still do not get adequate training with live transfers. Next slide. So the question is, what is the role of embryo transfer simulation in fellowship training? Next slide. Well, first, it certainly could be the initial training for embryo transfer. Our hope, and we'll show you our data, is that skill building will result from the simulator as well as development of confidence. The days of see one, do one, teach one are really relegated to history in every area of medicine for which procedures are taught. We felt that simulation could fill in the gap for programs that historically haven't allowed fellows to perform transfers, and that it's likely the next best substitute for live embryo transfers. One of the things we found is that as fellows have completed the certificate course, the training program, that in fact, their programs are more likely to let them do transfers even though they hadn't prior to that time. Next slide. So then the question is, embryo transfer simulation, what has it accomplished? Next slide. Well, our training program revolves around the ASRM Embryo Transfer Certificate course. And there are two parts of this course. One is an online component that's completed over 2 to 4, or rarely more, hours of work before the hands-on workshop. And the online component begins with a 22-question confidence survey, which is repeated after the hands-on workshop. The online component has didactic information, literature reviews, and instructions for hands-on workshop. And there are 4 self-assessments throughout the online component, all that have to be completed successfully before moving on. The fellows then come for approximately 1.5 two-day hands-on workshop. And that workshop is divided up into sections. The first is the basics of performing embryo transfer with direct and trial transfer techniques. The second session is the basics of performing embryo transfer with afterload and trial converted to afterload techniques. There's a continuing practice session to go back and review and get more repetitive learning from the previous sessions. And then there's the basics of performing the difficult or potentially difficult transfer. After each of these sessions, there's a debriefing, and the fellows talked with each other about what was difficult, what was not difficult, what was easier, how did they get it through the difficult transfers, and what did they learn? So now let's look at what we found. For the nearly 100, we had 78 fellows who completed the certificate course, and a paper of which was published in Fertility and Sterility this past month. So let's look at this overview. First of all, for 58 fellows performing 5 direct transfers for uterus A and B, we demonstrated significant improvement of skill for all of the analyses performed. We then looked at the afterload technique. We had 57 fellows who had completed 5 transfers for each of the 4 uteri A, B, C, and D. If we can move to the next slide, you can see here that uterus A is the top dotted line that's pretty much goes straight across. This is kind of our control. It's an easy uterus to perform transfers on. It gives the fellows confidence to move on. The bottom 2 curves are C and D, and you can see that they improved gradually in each step along the way to the 5 transfers that they did. So each of them improved and came to the same level. D is one that improved from the first to the second transfer. It's like once they got it, and from then on out, it stayed pretty much the same. Can you move back a slide, Keith? Now, after the next thing we did was to look at the skill of the 57 fellows, dependent on whether they had done or performed any or a large number of live embryo transfers. And you can see that the skill for afterload technique improved for all levels of prior experience, except those fellows with greater than 50 to 250 live transfers. But they started and finished at higher levels of skill. And it demonstrated that even if you've had live transfers, you can still learn and improve your skill. The last bullet here looks at all comparisons of self-confidence. So we had them rate themselves on a 6-point Likert scale in performing 22 parts of the embryo transfer before and then at the end of this survey, or at the end of the workshop. And all comparisons of self-confidence improved significantly, even in those with prior experience. And again, the fellows who had prior live experience started at a higher level of confidence, and they finished at a higher level. Last slide, please. Next slide. So in summary, fellows have historically in the US performed relatively few, if any, live transfers in at least half of REI fellowships. The ASRM Embryo Transfer Simulator Certificate course has been validated as a tool to improve fellow skill and confidence, as shown through its publication in Fertility and Sterility. While not yet studied, the ASRM Embryo Transfer Simulator certificate course should similarly help improve the skills of seasoned clinicians. We have dealt a little bit in this, but this is one of the goals of the simulation program, is to get to those seasoned clinicians and to see how we might improve their success as well. So thank you very much again for allowing us to share in this very interesting meeting. Thank you.
Great. Thank you both for a fantastic presentation, and really congratulations on putting together something that I think is really providing incredible value to the field. There is a question about whether this would be available to people outside the US at any time, which you alluded to, but there's also a question of whether you might develop something similar for retrievals, because it's such an important step as well, and there are staff differences, and whether that's something that is in the works.
So in regard to the question about doing this training outside the US, we have done some half-day workshops, day workshops. They're certainly not the certificate course workshop for most international meetings we've gone to. We have, however, been able to show that the certificate course works well. We've done it in Argentina and in Mexico, and we in both countries, and it went very well. The simulator comes with a guide to learning, and the guide to learning really parallels the certificate course. So if any country or medical society or wanted to buy a simulator, that coming with that is the guide to learning, which they could then put on these programs as well. Keith, you might add to that.
No, I think you touched on it perfectly.
And the second question was?
Oh, just regarding whether you're going to develop something for doing egg retrievals as well.
We really debated this a lot when we first got started. And in fact, the simulation company we worked with, Vertimeg, we entertained the thought of whether to do that as well. We felt that that of the two, that in fact the embryo transfer was more critical in learning, and so we elected to do that first. Whether the ASRM goes back and does, may or may not in the future.
Okay, great. All right, well, thank you for that. Now I'm going to invite everyone to join back in turn on your videos, please, because we're going to enter the general Q&A session. And while we're doing that, I have another question for the embryo transfer team there, that last presentation. There's some evidence that you were using the outside catheter, guiding it in, and curious, during the training, is the part of the training involve how far you advance the outside catheter, as it is definitely rigid and can cause some irritation in the endometrium? Is that something that is part of that training?
Yeah, that absolutely. So we in our training, in our workshops, we actually will advise that you only will need to bring the outside catheter just past the internal os. In that video that I showed, I went a little further, but then you saw me backing out on that particular video. So we believe that you just need to clear the internal os, make sure your path is open, so that way when you come back through with a loaded transfer catheter, you don't run into any obstacles when you have the embryo loaded.
So can we just also get confirmation from everyone on the positioning of the getting past the internal os with the external sheath? Is that Brad and Daniel? Is that how you guys practice?
I pull it back. If I see the tip get into the endometrium, I pull it back inside the internal os.
Yeah, I agree. I try and advance the outer catheter just to the internal os, but not past it. And then I use the inner catheter to cannulate further into the endometrial cavity.
Yeah, that's exactly what we do too.
What percentage of time do you think you, by mistake, just a little bit advance into the endometrium?
Often. Often. I'm not sure that it makes that much of a difference, because the outer sheath of the catheter that we use is, it has like a little kind of bulbous bevel. And so it's atraumatic. As it goes through the internal os, you can kind of feel, we can see it, but if it happens to be obscured on the image, you can kind of feel when you get there. And if I feel the little pop, just pull back. So the distance we traverse is, I mean, it's 2 millimeters, whatever the bevel is at the end is what's going in there. And since the catheter tip is going to go at least a centimeter past that, I'm having a hard time thinking that that's impactful. It wasn't addressed in the literature review that I looked at. So
for the purposes of the simulation, what we've done in the next iteration of the software that's coming out for our simulator, we'll add the metric. We are adding the metric that if the external sheath is too far in, you're deducted points, because we want the learner to practice just getting past the internal os, and that's it.
Keith, is it how far is too far?
So I mean, just clearing it. So probably less than a fourth of a centimeter. I'd have to go back and look and see what they're actually.
And in essence, the reason that we have them go just past the internal os is primarily because the sensor of the catheter has to recognize that it is at that position.
Yeah.
So,
Yeah.
Okay. Peter, you want to?
Yes. There are many questions, and I'm afraid that we will not be able to ask not even half of those questions. But I think one that is a very practical question that comes up, unfortunately, more frequent than we would like to see, is that there is a patient that you stimulated, you trigger the patient where the number and the follicle size is at the right place at following your protocol, but then you get a relatively high proportion of immature of X. Patient comes back for the next treatment cycle. Do you do anything different? Modify the protocol? Do you stimulate the patient longer? Do you do anything else? And I would like to start with Dr. Van Voorhis and Dr. Sparks to answer that, but then anybody else can later on chime in.
Yeah, that's a difficult question to know exactly what to do. The things that we consider are pushing to a larger follicle size. Another consideration is to change the trigger that's used to see if they respond better to a different trigger. If you use Lupron to begin with, maybe go to HCG. And then a third option is to consider increasing the time between the trigger and when the retrieval is done. Those are all things that we've considered, but truthfully, just doing another cycle often alleviates the problem. In other words, it's not always a repetitive thing. Fortunately, it sometimes you just get some immature eggs, and the next time around, it spontaneously reverts without doing anything different. But still, those are some of the things that we try. I'm not sure there's great evidence that any of them make a huge difference.
Right. Anybody else? Dr. Shapiro, you want to comment on that? The microphone is off.
No, I think
Your microphone.
I think they covered it. But yeah, there are the questions.
Perfect. Thank you. And just to tag along to the same direction, is there a better timing between the trigger and egg retrieval? Let's say 34 hours versus 36 versus 38. Any suggestion there?
We use 36 hours and have been happy with it. We used to go 34 and a half hours. We were concerned that at that time we didn't have dedicated anesthesia, and we were worried if they couldn't make it, we might miss the retrieval. So we went on the early side. Since going to 36 hours, we feel like we've gotten some improvement in outcomes, but it's a little hard to know if that's just other improvements in the program or if that was the factor. But Amy, do you have any comments about what you've observed?
Yeah, I just felt like our ICSI rates, our fertilization rates with ICSI improved. We didn't change the time to insemination relative to the HCG time. We kept that the same. So we're doing ICSI. We do it a little bit later than most. We do it at about 5 hours post-retrieval. So that's going to be 41 hours post HCG. When we were doing the 34.5, we did need to have that leeway because sometimes anesthesia was tending to labor and delivery and we would have to delay cases. So that was very intentional. I'm glad we've gotten away from that.
Daniel?
Yeah, Peter may recall that for a while we tried pushing people to 38 hours for retrieval. This is a while ago, but we were doing that for a while under the theory that we would have a lower rate of immaturity. But I mean, the truth is the immaturity is either concentrated in the same patients over and over again, or it seems to be kind of random. We went back to 36 hours because it wasn't making any difference at all, and it was driving the nursing staff crazy. So,
can I ask Daniel? So we do 38 hours when we see a poor maturity case repeated. We'll change triggers, like Brad said. We'll go to 38 hours. Did you see more incidents of premature ovulation or not getting eggs, or was it fine? You just think 36 is safer?
I think 36 is what's been established in the literature for 35 years, and it seems to work. We've had one documented case of true premature, not just luteinization, but actual egg release before 36 hours in the last year that I'm aware of. I did the retrieval, and there were supposed to be 15 follicles, and there were 3, and a ton of cul-de-sac fluid, and I pulled 5 eggs out of the cul-de-sac. So, but that's the only case where we've got clear evidence that ovulation happened before 36 hours. So I think that, and the maturity rates are adequate. We're not an LH add back practice. We use it a lot, but judiciously, not on everybody. We have a bias toward FSH only protocols. And so if we see a high rate of immaturity, we tend to add the LH back at that point. That does seem to make a difference in a handful of patients. It does not help everybody.
Thanks. Okay, well, while we're on retrievals, one of my other experiences practicing around the world is the variation in doctors' retrieval stats, KPIs. And so we know that we've covered a lot of the differences in pregnancy rates for those doctors doing transfers. But I'd like to start again with Brad to say, have you, in all your years of training fellows, have you had some trainees who haven't had as good of recovery rates, or anybody in terms of in general with their practices? And then what have you done, and have you been able to correct that?
You know, I don't think that we've seen as much variation. Amy's the one who keeps those stats, so we'll see if I'm right. But I don't believe that there's been as much variation in egg retrieval rates among physicians as we've seen for embryo transfer rates. So in other words, I think that that's, you know, after the learning curve is pretty fast, I would say, for an egg retrieval. And we're, you know, watching very carefully for the early fellows. And truthfully, you know, after their first 25, 30 retrievals, they're pretty competent, even if I weren't in the room. But I'm always there. And so we don't see fellows having poor outcomes routinely.
That's probably, yeah, it speaks to your training in the system. Yeah.
So Dean, the one thing we did change though, for a long time, we were having nurses report the number of follicles that were aspirated, and we used that as our denominator. Frankly, that was the bigger variable. So when we switched to just using follicles greater than 10 millimeter at trigger, that's where we're seeing even better just consistency. And I think that's a more reliable number. Nurses lose track sometimes, double count.
Daniel, do you see any variation in Atlanta?
Lots. I would say most of the variation that we see between what's expected at retrieval and what actually happens is more related to ultrasound though. We have 5 ultrasonographers, and some of them are newer, some of them are not so new. Some are reliably measuring outer to outer on each of the follicles. Some it's a little bit more haphazard, and there's some remediation every now and then. So the follicle counts also, it's once they get below 1.1, they say, plus, and then they kind of make up a number. And so when the patients see that number, they think the 1-0s are going to count. And so when I come in and I do the count, I set expectation low and say, well, here's what's 1.4 and above. That's what we expect to be right. But it still might not be. Well, but I didn't only have 12, I had 20. I'm like, yeah, but the other 8 are all very small. They might yield a usable egg, but probably not. Then it never feels that bad when I come out of the back if the number's lower than we expected. And often it's higher because we talk about the 1.4s and above to avoid the quandary with the patient. In terms of efficiency at retrieval, I think all of us are pretty close. The only thing that's really different between the doctors is the time it takes. We have some who are, and we have one,
Yeah.
or it's just forever. Yeah.
I don't know if you remember, Daniel, I did pickups in Atlanta in 1998 when after Michael left.
Yeah.
And you were the fastest. So I'm just going to point this out.
He is, yes.
Wow.
Yes.
But that used to be a competition between me and the practice founder. It's not a competition now. It's that we're that busy. If I don't keep on, we will not finish, and I will not get to eat, and I will get agitated and start screaming and yelling. So it's always better to keep on time. At least once I get here, I'm always late to getting here. That's the difference.
It is a question from Michael Reed, and I think that's mostly for Dr. Reindollar and Ray. So he's asking that physicians that have been using the simulator, how is their IUI procedures? With other words, does the performance is improved when somebody is trained for embryo transfer on that simulator? Do you get a better IUI performance too?
The IUI performance, we actually haven't looked at that. We actually have an IUI module on the simulator and really haven't used it yet. Right, Keith?
That's right. Yeah. Mm-hmm. Yeah,
So I can't answer that question. We don't have data that correlates the simulator with IUI.
Yeah, on the embryo transfer side, what we're seeing though is that a lot of the programs are now allowing more and more programs, I should say, maybe not all of them yet, are allowing their fellows to do live transfers after they've completed the certificate course, after they've demonstrated some skills there.
That makes sense, absolutely.
Yeah.
And there was a study from the Brigham that looked at performing a learning module which involved IUI/mock transfers before going on to live transfers versus not having that prior training. And they didn't show a difference in pregnancy rates after that.
Right. Then there is another question regarding how accurately the pumps that you use for egg retrievals is adjusted for the pressure. Is there a way to measure it? Any handheld device or other way to measure it? I think it's important that you make sure that you have the correct pressure. Dr. Voorhis.
Yeah, I don't know. We don't use anything other than the gauge that's on the pump that we happen to use. It comes with a gauge, and we just occlude the end of the suctioned tubing and watch where the gauge ends up and set that at 100. I haven't measured against any other parameter other than the internal gauge on the pump, if that makes sense.
We've done that with just doing a flow rate, actually measuring how quickly the media gets aspirated as a indicator of that pressure.
Makes perfect sense. Yes. Is it sometimes changed? Like, for instance, I don't know if you do any IBM patient where they would, recommend probably a lower pressure. Does it happen? So would it be changed at any time, or you are just leave it as it is? It's set as it is, and everybody is using guess.
Yeah, we leave it as it is, set it at 100 and go with it. No, it hasn't been a technique of mine to change the aspiration, the suction to try to troubleshoot a retrieval. I haven't done that. Have you done that, Daniel?
No, but we have an analog. So the dial has the numbers written on there, and it's an ancient machine, and there's no digital anything. And we set it to 150 millimeters of mercury. And I can just tell by how quickly the follicle collapses on screen if it's drifted too high or if it's not high enough. And I'll stop and I'll say, can we check the pressure? They lift up the drape, they look. If it's not right at 150, they move it a little bit until it feels right and the rate of collapse looks right. We probably need a new machine, but no, we've never put a gauge on that thing to try and figure it out.
Pretty sure that's expired, Daniel, that you need that piece of equipment needs to be retired.
I'm not the one to talk to. But yeah, we need a new machine.
Yeah. All right. Time for a few more questions. This one directed towards Daniel and Peter, actually Amy as well, but let's start with probably Peter. And this comes from Allison Campbell. I thought the use of air when loading embryos for ET was primarily for improved visibility with ultrasound. Modern catheters and ultrasound enable clear visibility, and I see no benefit of using air gaps. Have you tried it this way? And then also is this from Jacques, is there any circumstance where air naturally occurs in the uterus, and where does the inserted air go? And has the use of air ever been tested in prospective investigations?
Thank you. That's long and many different questions. Let's start in the beginning. First of all, Alison, I'm so happy that you are here and watching this webinar. And thank you that you have been so many times in the past also participating in that webinar. So the air pockets, yes, you are right. It has been used also to give a better visibility for the catheter. It's true that today's ultrasounds, they are much better quality and show much better pictures. But having air, it is still pointing it out very, very clearly where the embryo is supposed to be. So, the use of air for that purpose still serves. The other reason I think is important, because if you have air, then you know that the embryo stops there. It cannot go into the air. But if you have a single column, for instance, the embryo can move, can shift. I don't know if you have observed this, but the embryo can really move around quite a bit. So it does have benefits for both purposes. I don't know, Amy, if you want to add something to that point.
No, I agree with you. The embryos can move when you have a continuous column. And yep. We are putting, it's 3 to 5 microliters of air. So these are small air bubbles. I think the visibility is more important than being consumed with what's going on with that little bit of air.
Yeah, my feeling as a clinician is that the patients can see on the ultrasound screen where the air fluid interface lands. And as long as they can see it, they have faith and confidence that the embryo is in the right place. And so if it doesn't hurt transfer pregnancy rates, I'd prefer that it be there so that we can say, see, there's the dot.
And then I ask the question that where the air goes.
The air gets absorbed, like one would imagine. Slowly, it diffuses into the tissue and then eventually gets dissolved into your bloodstream and gets breathed out.
Can I just, on that point about the patient experience, Keith and Richard, when you do the modeling, do you do it with air or without? And do you see a flash with just media? Because I believe we still get a flash with just media. Oh, you need your microphone.
Go ahead, Richard.
Actually, and Keith, correct me, but it's all air with ours.
That's correct.
So that, but we do see the air bubble, and it measures the velocity of the expulsion.
So we have no fluid in our syringe. It's a dry lab completely.
Okay. Thanks.
Mm-hmm.
All right. Well, everyone, it's been a great discussion, and we're out of time. There's so many more questions. We'll try to answer some of them offline later. But with this, I'd just like to conclude again, thanking the sponsors, Cook, thanking ASRM for their great participation with the simulator. And with that, I'll just say that we have our next session already excitingly planned for next week, which is called Ex Utero, a session devoted to the extended culture of embryos in vitro and past implantation and the finding of recent publications on ectogenesis. The moderators will be Professor Susana Chuva de Souza Lopez and Professor David Albertini. Excuse the pronunciations. Albertini will discuss Brave New Lab and introduction to the latest developments. Bailey Weatherby will discuss symmetry breaking in the human embryo. And Alejandra Aligera Castaron will present on in vitro culture of post-implantation embryos. So this session should be fascinating, extending human embryo culture and groundbreaking paper by Hannah's group with embryogenesis in a bottle. So thank you again all for joining us today. Thank you, Peter. Thank you all of the guests. And we look forward to seeing you next week.
Thank you very much for everyone. We really appreciated your participation. And see you next week.